welcome you all to our awareness program on World Alzheimer's Day. Every September, people come together from all around the world to raise awareness and challenge the stigma that persists around dementia.
Thank you, September. Your video.
September 2020.
Renuji, we can't hear you. You have to unmute yourself.
तो ऐसा कर लें कि मतलब जो बोल
रहे हैं वही अनम्यूटेड रहेंगे. बाद में सबको बोलने का मौका दिया जाएगा. अभी प्रोग्राम में अभी सिर्फ जो बोल रहे हैं वो अनम्यूटेड रहेंगे. धन्यवाद. Renuji, please proceed.
Yeah, can you hear me now?
Yes, we can hear you now.
Okay, let me start again. I welcome you all to our awareness program on the World Alzheimer's Day. Every September, people come together from all around the world to raise awareness and challenge the stigma that persists around dementia. September 2021 marks the 10th year of this vital global awareness raising campaign. The World Alzheimer's Day theme of the year 2021 is No Alzheimer's, No Dementia. And it is all about the power of knowledge in recognizing the signs and symptoms of dementia. A delay of few weeks or months can prove critical for persons living with dementia, as they can lose the early diagnosis window of opportunity. To achieve success, early intervention with medication and care management is essential. Our eminent panel of doctors will enlighten you on that. Now I have the honor to invite Dr. Manjari Tripathi, Professor, Department of Neurology, All India Institute of Medical Sciences, and President of Alzheimer's Related Disorders Society of India, Delhi Chapter, to launch our website and release our newsletter. Dr. Tripathi.
Namaste, a very good evening to all of you. And it gives me great pleasure in having all of you. I'm unmuted. It gives me great pleasure in having you all on this platform. This is the new way of interaction, something which COVID has taught us. It gives me another very good, joy and happiness to inaugurate our website. We had a website before, but it's got, completely refurbished and renovated, you can say. And it is, with this, I'd like to offer my sincere appreciation to Nav Chatterjee and his team of Lazy 8 for sponsoring our new website, ARDSI We've always wanted young people to come forward and get involved with the cause of Alzheimer's, and his team with his young colleagues have done a great job for the cause. A big thank you to Nav and his team. And with this, we can, go ahead with the website site. Narendraji? So, Narendraji, can you show us the slides of the website?
Yes, ma'am. I'm just.
So, we have the homepage which talks about the history. We have the homepage which talks about the history of Alzheimer's disease, the symptoms, what patients can have, the warning signs. So all of you logged in here are welcome to visit the website, ARDSIDelhi.org. So ARDSIDelhi.org, and you would be able to get all information which is going to be talked about here on the website. It also has frequently asked questions which caregivers ask. So this is a website, and we have information about Alzheimer's disease. We have, a vision statement. We also have other sections of the services which the ARDSI Delhi chapter offers, of the daycare facility, of the free medication facility for poor, as well as our newsletters. So I welcome you all to go on to the website after the talk. If you're interested, definitely you should be interested, because this is kind of, it gives us a lot of information about, Alzheimer's disease. And sometimes we're not able to answer all queries online, so they will be available. All helpline numbers are available here. So whenever anybody wants to seek an appointment, they can send an email or ask the helpline numbers. The helpline is attended to by our office staff, who diligently report any, calls which are there, and then tell us the purpose of the call. The services offered by the Delhi chapter are counseling of caregivers, then of course volunteering for caregiving, information as well as training, and of course free neurological checkup with consultation for cognitive complaints like memory at both the AIIMS as well as the RML Hospital, Delhi. So with this, we can move on now. And thank you once again, Nav and their team, for putting this together for us. And we hope to have a very good collaboration with you all, with regular updates on this website. Thank you. Renuji? Renuji? Renuji?
Hello.
Yes, Renuji, kindly take over. Yeah.
Yes. Thank you, Beena, for helping us launch this new website and bringing out our newsletter as well. Now, Dr. Tripathi will now release a third edition of the Caregiver's Handbook. We are grateful to Mrs. Jayanti Banerjee for supporting this edition in memory of her mother, Mrs. Abha Basu.
Thank
Narendra,
you.
please show the
So
cover of
I'd
the
again like to state that this caregiver manual has a long history to it. It was originally written by me. I forget the year now, and they will have to remind me. And of course, we had very limited copies of it. In fact, none left at all. When we got a grant from and a benevolent donation, and we are thankful to Miss Jayanti Banerjee in the memory of her mother, Mrs. Abha Basu, for helping the Delhi chapter with now production of more copies of this caregiver handbook. The caregiver handbook is available in English and in Hindi. You would be pleased to know that almost all of our patients who come to AIIMS get the caregiver manual free of cost. And we look forward to the Hindi version also. So again, this caregiver manual has several pages of information for the caregivers, how to handle symptoms and signs, and how to handle troublesome behavior by simple, common, tricks or diversions or, acceptance, attitude, and different kind of interventions which caregivers need to know about. Written in simple English and Hindi. Thank you. Thank you again once again for this gift. So we can move on now.
Yes. Now I'll invite Dr. Manjari Tripathi, President of ARDSI Delhi Chapter. She will deliver her talk on the topic, no Alzheimer's, no dementia.
So since the theme of the World Alzheimer's Day is no Alzheimer's, no dementia, I will be talking about knowing dementia and mentioning about Alzheimer's in that. And Dr. Anu will follow me. She'll be introduced. She'll be talking about the challenging behavioral concerns which families and caregivers have when their loved one has dementia. These are our helpline numbers, and this is our email. We are there to help you, and please feel free to access this resource, which is available to all in North India and elsewhere also. Now, we know that we are an aging population. We are successfully aging, and this upper age is increasing because of good health facilities which we have. So if you look at this world map, in 2020, it was projected that 1 in 8, will be elderly, okay, as compared to 1 in 20 in 1990.
1 in 8. Anyway, I'm going for
And worldwide, if you see,
Ma'am, you are muted. You will have to unmute yourself. Dr. Manjari, yes. No, we can't hear you. You're muted, ma'am.
Narendra ji, are you able to hear me now?
Yeah. Yes, ma'am.
So don't mute me. Don't mute the speaker. You mute the others.
Oh, sorry. Yeah.
Yeah. So there is an upswing in the numbers, and we see that the number of dementia cases or the major neurocognitive cases, the numbers are in the upswing. It's going to reach 115 million in 2050. And around 2030, which is really, just coming, it's going to be 66 million. Now, in India, the numbers are around, 4.7 to 5 million as compared to the world, which is 50 million right now. We need to build our reserves and resources, and ARDSI Delhi Chapter is a part of those reserves and resources. The Dementia India report, which gives us details about the condition of dementia in our country, the first of its kind from a developing nation, was released in 2010. And you'd be surprised to know the huge cost which the society has to bear for a person with dementia. So to minimize these costs, we should be aware of what the symptoms are so that the patients come in early, and we should be aware of the preventive modalities so that we can prevent cognitive decline in our population to make it more meaningful and give them a quality of life, particularly when they are elderly. Now, dementia is not a single disease. It's an umbrella term. It's a big umbrella. Imagine a big umbrella and then number of conditions under it. The first of which, and the commonest of which, is Alzheimer's disease. In our clinics, it's around 60% formulates Alzheimer's. The rest, 35% is vascular dementia, which is due to multiple strokes in the brain. Sometimes these strokes are silent. That is, there are just white matter changes in the brain. So they're silent lesions in the brain which haven't manifested with a stroke, which is known as, subcortical leukoencephalopathy of Binswanger's type. And that causes vascular cognitive impairment, which is the second commonest cause. Then, of course, we have another common cause where there are Parkinsonian symptoms. That is, the person becomes slow and Parkinsonian, but along with that, there are hallucinations. They start hallucinating towards the bedtime or towards the evening time. So this is diffuse Lewy body disease, which is again very common. Then, of course, we have frontotemporal dementia, which is really a very difficult dementia where they are disinhibited. can be, indifferent, apathetic, or they can have language dysfunction. Along with that, we can have patients who have Parkinsonism and then develop dementia and become slow, and not only in the physically slow, like in gait, but also in the mind. So apart from that, there are many other causes, like in our context, people with, taking certain medications, over-the-counter medications taken for a long time can be an important cause of cognitive decline. Now, what does dementia do? We know the conditions. What does dementia do? Dementia affects the, whatever you call, of existence. It affects the A, which is the activities of daily living. It affects the B, which is it affects the behavior. And of course, it affects the cognition, which is the ability to memorize, to remember, to understand, to plan, to judge, to execute, to do things, to read, to write, to calculate, to recognize, to find the way in an area where we have been going frequently and not getting lost. So that is cognition. So dementia affects all these three domains. And for diagnosing dementia, we have to go to a cognitive disorders clinic or a memory clinic, which is there at AIIMS, RML, and many other hospitals, and get certain tests done, the commonest of which is a MMSC or a MOCA, a neurological examination, a detailed history, a detailed cognitive screening, which takes about an hour. And of course, there is a lot of lab tests which are done. And these tests involve the patient's cooperation, pen and pencil tests, sometimes they're computerized tests. It takes time and patience. And then we reach a conclusion whether this person has
Garden Association की secretary हैं.
Now, so cognitive complaints are the first, and then behavior also comes in, and it affects the activities of daily living. By far, the diagnosis of Alzheimer's is a diagnosis of exclusion. Before we arrive to a diagnosis of Alzheimer's, we have to have done the serum B12 levels, because low B12 can also present with symptoms of dementia.
You are muted again, doctor.
Sorry, doctor, you are muted again.
Narendra ji, I am not muting myself. When you are doing a global mute, you are muting me also. So the muting is not happening from my side. I'm sorry for this. So the toxic and drug-induced causes are taking antidepressants for a long time, taking antacids for like H2 blockers like pantoprazole for a long time, taking amitriptyline, taking sleep medicines for a long time can cause cognitive complaints. So we have to rule out all of that. We have to rule out strokes in the brain by doing an MRI. And then, once we find that everything is okay, but still the person has a slowly progressive decline in memory and cognitive functions, which I just enlisted, then the person has probably got Alzheimer's dementia. So as I told you, we do various battery of tests, and this is just to show you the kind of tests which are done. You don't need to remember these, but the doctor and the psychologist will do them. We do an MRI of the brain to see for shrinkage in certain areas. As you can see here, there's shrinkage here in certain areas. We also do a PET of the brain. PET brain tells us the metabolism of those areas and helps us see the metabolism is grossly reduced here. So that would indicate that there is Alzheimer's disease. And this will show metabolism decreased the front part of the brain, which would tell us there is frontotemporal dementia. Okay. Now, when we do the MRI, we find strokes in the brain at multiple areas. So that can also cause dementia. Okay. Now, another thing which is very important is to rule out conditions which mimic dementia, like depression. If a person is elderly and depressed, then they can present with dementia-like symptoms, and that is known as pseudo-dementia, and hence whenever there is a doubt, the doctor may actually start antidepressants and see if the cognitive complaints clear over a period of 6 months. So the person may be having a pseudo dementia, which is due to depression. So that is the job of the clinician, to rule out depression also, not just B12, not just thyroid, not just vascular, not just, we have to rule out all these conditions before we say you have Alzheimer's dementia. Now, it's not uncommon that before a person gets dementia, some amount of depression comes in. So depression can also be an harbinger of dementia. Okay. So both can coexist as seen here. You can have depression and dementia in the same patient, and commonly they can have vascular cause also, that is strokes in the brain. So the symptoms of dementia, one should recognize that there is memory loss. Okay. It's a memory loss which begins very insidiously. Slowly and slowly they start forgetting whom they gave money to, how much money they had to get back, where they put their stuff, where they put their important documents, what they had for breakfast, or the fact they even had breakfast. They keep asking that I have not had my breakfast, give it to me. So these kind of memory complaints to recent events. Remember, the past events are preserved. Sometimes the patients, caregivers are fighting with us, saying, Doctor, inko to purana yaad hai, purana hamesha yaad rahega. Because the remote memory, which is the purana memory, 20 साल पहले क्या हुआ, स्कूल में क्या हुआ, that is the last to go. What goes first is the working memory, which is the immediate memory. What is being done in few seconds to few hours to few days, that goes first. Okay, so that is important to remember. And sometimes it can become really grave. The memory loss can become really grave and can impair the functioning of the person. So why doctors are telling that dementia awareness? Why no Alzheimer's, no dementia? Because you look at the green here. The success of a doctor's intervention, the success of a psychologist's intervention, the success of a counselor's intervention will depend on how early the patient is gotten. And the earlier you get the patient in for the memory complaints, the faster is the success of intervention modules, treatment, medications, which is there. So get the patient in the early stage or even the preclinical. Just go for a memory checkup and find out what your memory will be next year. If you are having a strong family history, or if you have a high risk of cognitive impairment, if you're hypertensive, if you're diabetic, and if you have, had issues with forgetting things, get your memory testing done, come in early. Okay. So that is the message. Then these are the symptoms which Dr. Anu will be talking about. These symptoms, they kind of replicate and amplify the caregiver burden. Behavior abnormalities amplify caregiver burden, agitation, wandering, aggressiveness, blabbering, purposeless activity, depression, sleep disturbances, psychosis. All this is troublesome for the caregiver. The patient, of course, is disturbed, but he's unaware because he has lost his memory or is losing his memory. It's the caregiver who is burdened with all of this. The caregiver is also burdened with the fact that the person with dementia, Alzheimer's in particular, starts falling in his activities of daily living. So what are these activities of daily living? They become dependent slowly for simple activities like brushing teeth, like bathing, like eating, like dressing, like toileting, and even moving about. There can be instrumental activities which are affected, like handling a phone, like handling a toothbrush, doing the laundry, housekeeping, etc. So these are also increasing the burden of the caregiver, the behavior and the activities of daily living. So A, B are the major problem for the caregiver. The C is a problem for the patient and to a certain extent for the caregiver, particularly in the advanced stages. For the C, for the memory loss, it is required that all elderly in our country sit down with their family and talk about their finances. Make a will. It's necessary to make a will when you are of normal sense. If the elderly above 60, above 55 have not made a will, And if dementia develops, there can be legal issues. There can be issues which people face, because by the time dementia comes in a big way, they would have forgotten how to sign, and there would be important documents. The family would not be knowing. So, because the cognition is impacted, because activities of daily living are impacted, because reading and writing is impacted, these are things which we need to consider. It's the job of the doctor to give the medication, but it's the job of the family to sit down together and discuss this with elderly people in our country. The carers also need to be trained. This is what the Dementia Society does. We give useful tips of how the caregiver should handle their patient. So the caregiving needs to be trained and customized to the patient's ability and the patient's disability. And of course, as I told you, multiple domains are involved. The activities of daily living are involved, the behavior is involved, the cognition is involved. We have to address all these domains. It's not one magic pill. It has to be a multifaceted, multidimensional intervention which is done. And this is what our volunteers do. This is what our secretaries, member secretaries, all of us do. And you can see Renuji here. And, they spend hours. And of course, in COVID time, it's generally an hour of conversation on the phone in divided intervals, where they give help to the caregivers through our Delhi chapter. And please avail these services with a helpline. For a caregiver, it's not a 24-hour day, it's a 36-hour day. The day is never ending, because they have to look after themselves, plus they have to look after a grown-up child of a person with Alzheimer's disease or Alzheimer's dementia. So we have to be sensitive to their needs and understand that we are in all of this together. So with this, I'd end my talk and hand over to Renuji to introduce Dr. Anu. Renuji? Renuji? So I think Renuji is not being able to come online. So it gives me great pleasure to introduce Dr. Anu Gupta. She's a dear colleague of mine.
Yes. I have the pleasure to invite Dr. Anu Gupta, Assistant Professor, Neurology, AIIMS. She will deliver her talk on the topic, Challenging Behavior of Dementia. Dr. Anu.
At the very outset, I would like to thank ARDSI Delhi Chapter and Professor Manjari for giving me this opportunity. I hope you're able to see my screen.
Yes, we are able to see you and hear you also. We can see the screen.
Okay, thank you, ma'am. So today, after Professor Manjari gave an excellent account of what dementia is and how one can have an understanding, a wholesome understanding of dementia patients. So I will be focusing on one of the difficult aspects in dementia, that is challenging behaviors. So dementia, as ma'am said, is an umbrella term for loss of memory and other thinking abilities. And this loss is severe enough to interfere with daily life activities. Behavioral symptoms are a significant concern in these patients because difficult behaviors are common in dementia across the different etiologies that we see. They lead to a reduced quality of life in the patients and are a source of distress and burden to the caregivers. They become a barrier to care and they accelerate functional decline in these patients. So, what are these difficult behaviors? These behaviors are actually response to a stimulus in patient's internal or external environment. Or these behaviors may be the patient's attempt to communicate an unmet need. So in literature, we use the term responsive behaviors. So it is important to understand these behaviors in the context of a stimulus in the internal or external environment, or an unmet need which the patient is trying to express through this behavior. So we can understand that a patient of dementia is just like a child. So the way a small child is not able to express his needs properly, if there is an unmet need, the child may throw tantrums, the child may become irritable. If the child is having some kind of discomfort internally or externally, the child may become irritable. So the similar is the kind of behavior of a dementia patient. So what are these common challenging behaviors? These patients may be restless. They may have pacing. They may, move fast, aimlessly here and there in the house. They may have a wandering behavior wherein they would seek to exit the house time and again. They may enter the rooms or personal space of others. This wandering may be aimless, purposeless, or at times they may do repeated activities which are purposeful. They may become verbally aggressive. The patients may scream, may shout. They may be physically aggressive in the form of kicking, hitting, tearing things, throwing things, breaking property. They may start manifesting a resistive behavior in the form of resisting food, resisting medicines, resisting care. They may do certain repetitive activities like picking the skin, banging their hand, repeated vocalization, calling for help again and again. At times, their activities may be socially inappropriate, like disrobing in front of others, picking up food from plates of others. Then there are certain symptoms related to psychotic behavior, wherein these patients may develop hallucinations, wherein hallucination is the medical term which we use for seeing or hearing that nobody else does. Or they may develop some false, firm beliefs which are difficult to shake. That is, they may develop delusions. So what are the stimuli which can lead to these kind of behaviors? It is very important to understand and identify these triggers, because working on these triggers primarily can help in alleviating these challenging behaviors to some extent. So as I said, the stimulus may be in the internal or external environment. So as for the patient, any pain, hunger, loneliness, boredom, emotional distress can contribute to these behaviors. A pre-existing personality or a pre-existing traumatic experience may contribute to these behaviors. As far as the environment is concerned, discomfort in the form of noise, clutter, and a temperature discomfort can contribute. There may be a relationship distress. And at times, the caregiver may have emotional outbursts, may argue with the patient, may try to overcorrect the patient, which can aggravate these behaviors. Even caregiver burnout can lead to aggravation of these behaviors. And it is also important to remember that at times when there is a sudden change in the behavior of a dementia patient, the cause may be a medical cause. For example, an occult infection, a hidden infection, which is not apparent in the form of fever or other symptoms. So the patient may have a urinary tract infection, a pneumonia, which is not obvious, but is presenting with a sudden change in behavior or a sudden deterioration. If the patient has not been eating well, they may develop certain imbalances in their electrolytes, like a low sodium, which can again lead to sudden change in behavior. Introduction of new medicines or a change in the dosage of medicines can also precipitate changes in behavior. So what can you do to assess these behaviors or to tap these behaviors? So first, you need to describe the specific behavior which is distressing you. And then try to see, is there a pattern to it? Is there a particular time of the day when this behavior is happening? What is the frequency? What is the duration? Is it happening in the presence of a particular person? Is it happening or getting triggered after a particular activity? For example, a patient who has a bed sore. You do a bed sore dressing, and after that, the patient starts using abusive language or becomes irritable or aggressive. Then probably it is the pain during that bed sore dressing which is aggravating this behavior. So we need to see if there are any identifiable triggers or stimuli to that particular behavior. Then the next thing, is the behavior unpleasant? Is it just unpleasant? Or is it actually producing harm, immediate harm to the patient or to the staff or to the people in immediate vicinity of the patient? Because that will help your physician or your neurologist to decide how aggressively to go ahead with the management of this behavior, whether the person needs some specific medications known as antipsychotics to tackle it. And then, what is your particular response when this behavior happens? And does that response aggravate the behavior, or does it actually help in reducing the behavior? So we can summarize this as an ABC charting. A is the antecedent or the trigger. B is the particular behavior, and C, the consequence. So let's see an example. Mr. BN, a 64 years old male, diagnosed as moderate to severe Alzheimer's, starts getting episodes of anger outbursts, wherein he uses abusive language, and that is creating social conflicts. The daughter reports that there is distress in the family due to his behavior, and at times, the patient is physically aggressive towards the son. So we ask them to do an ABC charting and look at the pattern. So the relatives find that there is one particular trigger, that whenever there are children playing in the street and there is ambient noise in the environment, the patient becomes aggressive and starts shouting at the kids. And there is also a background of emotional trauma wherein he was cheated by a close relative and he is worried regarding the future of his kids. His daughters are unmarried and his son has lost his job due to COVID. So he has repetitive thoughts and he's repetitively asking the son, what are you doing for your sister? Why are you not getting her married? Why are you sitting idle at home? So these are his concerns. So after identifying this pattern, we ask the relatives to put in a noise barrier so that when the children play in the street, there is less of ambient noise in the environment. Whenever he is raising concern for his son, for his daughter, we ask them to reassure the patient and to avoid argument. So this helps them and reduce the aggression of the patient. So if we go on to specific behaviors, for example, restlessness, what could be the triggers? The triggers could be a noise, an overstimulating environment, physical discomfort as simple as constipation, or sometimes there may be emotional issues in the form of depression and anxiety. So if you find that the patient is tearful, very negative, withdrawn, is not eating properly, not sleeping properly, or at times he has a fearful expression on his face, he keeps wringing his hands, he has a worried facial expression, there are continuous requests for help. So there may be actually psychiatric comorbidities, and addressing these may be. So the remedies will be as per the likely trigger. If there is noise, we can advise earplugs, noise cancelling headphones, or a calming music. We can treat the cause of physical discomfort. For emotional distress, we can involve the patient in recreational activities as per his interest. And for patients who start wandering, there are other options which we can follow. For example, the exit door can be painted like a bookshelf, or it can be covered with a sheet which will act as a visual barrier, or one can put a stop sign over there, or One can remove the visual reminders which remind the patient that he has to go out, like shoes or purse, from the immediate vicinity or the room of the patient. And one can reassure where he or she is. Some patients may start resisting food, medicines, and care. The common triggers for these are pain, infection, and psychiatric symptoms. So if the patient is not eating a wholesome meal at one particular time, we can give small portions more frequently. We can simplify the medicine schedule. We can feed the patient at the time when we feel that he's more compliant. There may be times in the day when the patient is more compliant with activities. We can use alternative formulations of medicines like liquid formulations, mouth dissolving formulations. We can hide medicines in food or drink.
बेटा अब ये बताओ
Request everybody to mute themselves. It distracts the speaker.
So before giving care to the patient, it is important to explain the patient what is being done. So just explaining in simple commands involving the patient, like handing over a towel or handing over the brush to the patient while giving care, may actually distract and involve the patient and help in giving the care. Then the type and frequency of care can be prioritized. For example, shaving may not be required daily. For patients who are too resistant, the care which is most important can be done first, like sponge bathing the perineal area to maintain a perineal hygiene would be more important than daily shaving. And calming music, playing calming music during the caregiving act may also help. Some patients start doing repetitive acts, which often arise from a need to soothe themselves, for a need to self-soothe. So here we need to see if there is a cause of physical discomfort, and we may also require to give individual attention for an emotional distress. They may also do repetitive acts if there is a lack of sensory stimulation. So it is important to get a visual and hearing assessment. If there is hearing loss, use hearing aids or pocket talkers. If there is vision loss, get corrective eyeglasses. The patient can be given toys or clothes with different textures. And the patient can also be engaged in purposeful activities like playing cards, painting, drawing, catch game, depending upon his capability and his prior interests. So sensory stimulation is important for these patients. If they start displaying inappropriate activities, it may actually express an unmet need for affection and intimacy. So the patient can be given a pet, a toy pet, for the patient to touch and stroke. If the patient is not displaying the inappropriate behavior, the patient can be given an incentive or a reward. If the patient is grabbing food from others' plates, then it would be better to not have the patient in the common dining room during meal times. For excessive oral behavior, wherein the patient is trying to put things into his mouth, one can use chewing gum or a wet cloth, and it is important to remove harmful objects from the vicinity of these patients. If there are hallucinations or delusions, one needs to see whether they are upsetting or not. If they're not upsetting, don't intervene. Also get a hearing and visual assessment, because lack of sensory stimulation aggravates these hallucinations and delusions. We also need to get a medical evaluation to rule out an infection or an electrolyte imbalance. The lighting of the room should be bright. It should be a good light. There should be no shadows. And do not directly disagree with a false idea. If the patient is expressing a false idea, rather than arguing and disagreeing, it would be better to distract and change the topic. And if the patient is having frequently losing items and blaming others for the lost items, if possible, it would be good to keep a spare set of frequently lost items. So some strategies are common and useful for all the behavioral challenges. One, use a calm, gentle tone. Give simple commands one at a time. If the patient repeats the same question, don't say, I've already answered. Why are you forgetting? Why don't you remember? Just answer like the first time. Accept inappropriate answers. Do not argue, do not correct, do not scold. Try to reduce ambient noise and clutter from the patient's environment. Get a correction done for vision or hearing impairment. Give a structured routine to the patient. So have a sleep time, wake up time, and schedule some activities which are outdoor as well as indoor. For example, a daily outdoor stroll for patients who are ambulatory. Sensory enhancement in the form of music, light massage, using pets, depending upon the patient's interests and capabilities. You may also plan some video talks or visits with friends and close relatives. And as I said, purposeful engagement, depending upon the interests and capabilities of the patient, would be helpful. So treating responsive behaviors is challenging, but sometimes a very small change can be rewarding. So our target will be to make the behaviors manageable. We may not be able to remove the behavior completely, but the target is to make it manageable. Non-pharmacologic strategies are as important as medicines, and it's a trial and error. One needs to persevere. So observe the pattern, identify the trigger, and address the behavior accordingly. Thank you.
Thank you, Dr. Anu Gupta, for your valuable insights on the challenging behavior arising out of stimulus and unmet needs of Alzheimer patient, and how to recognize and deal with them, or probably manage them. Thank you so much. Now, it is my pleasure to introduce our next speaker, Mrs. Sharda Subramaniam, who will speak on her caregiving journey. Her mother, Kamla Subramaniam, was a patient at our daycare center. Asha.
Thank you very much, Renuji. Very good evening to everybody. It is a little daunting to speak after two wonderful experts like Dr. Manjari and Dr. Anu Gupta have spoken, but I guess I'm just giving the the other side of the picture. So I presume I can also be tolerated out here. Before I start sharing my story, I think I have to put in a deep debt of gratitude to Dr. Manjari and the ARDSI for making my mother's sunset years, as I call them, a really beautiful journey. And for that, I'm internally grateful to the two of you, to you, the ARDSI, and to Dr. Manjari personally for treating her. I guess like most people, Alzheimer's remains a strange disease which happens to everyone else, and it's never going to touch us unless and until we really find ourselves, with one of our loved ones actually suffering from it. So when my mother, I'll call her Amma because that's what we always knew her as. And Amma was always this superwoman for all of us. I think like most of us, we all idolized her. We looked up at her. She walked in and owned every room that she walked into. She was a brilliant lawyer. She had already been an English teacher at Miranda House, at Kamla Nehru College, at the Patna Women's College. She was managing home. She was managing a profession. She would drive a car in the 60s. She wore the best, brightest clothes, loved her makeup, loved to cook, was a great hostess. So this was a person we all depended on. And my sister and I, for most part of our lives, thought Amma was the one who was the solution to all our problems. So when around the age of 75, when she was around 75, 78-ish, she began to forget things. Like most caregivers who have been through this journey will agree, we all start off with a denial. We are unable to accept that this memory loss is anything but something that happens naturally. And so you just kind of treat it as old age, a small thing which will go away. And so by the time you reach that stage where you begin to wonder what actually is happening, is there something really wrong with the person? A lot of time has already been lost. And what happened with us was exactly the same thing. So at a point when I realized that she was forgetting, we were kind of humoring her and saying, okay, she's reaching 80. She's obviously going to lose a bit of her memory. That's fine. And she was only forgetting small things like where she'd left the keys or whether she'd had her breakfast. So these are all tiny things. She hasn't forgotten us. She hasn't forgotten, I'd lost my father almost 30 years ago. So she hadn't forgotten any of those wonderful old things. So everything's normal. She's just kind of growing old. And then as time progressed, we realized she would come into my home every day, and my sister living in the US had given her a credit card. So every second day, my mom would walk in home with a gold chain for my daughter and say, this is a birthday present for Aditi. The next day she walked in again and said, this is a birthday present for Aditi. So it was only when I got the third, luckily they were small chains and didn't cause major problems. But by the time the third chain came in, I realized that there was something severely wrong. And because it happened through the spending of money, I immediately took charge of all her credit cards and called my sister and said, this is Alzheimer's, or this is some kind of dementia. We have to now get more serious about it. For knowing all that also, sorry, I'm just muting. Even though we knew of Alzheimer's, we had already heard of President Ronald Reagan and several such celebrities who had the disease. We were totally unprepared to deal with it. And I think the problem there is also that, when Alzheimer's strikes most families, it strikes the elderly, and the caregivers are at that age in their 50s or 40s. We, of course, I was a late child, so I was younger than many other caregivers. And I'm glad for that, actually, because had I already been 60 when Amma started falling sick, I might have found it even more difficult. But even though I was only in my 40s, and I'm probably not even 40, and I was in the middle of a very busy, challenging job, young children, demands from all sides, in-laws, everywhere, to suddenly realize that here was a person who needed nothing major except care and love was difficult. So we suddenly realized changes in her personality. We realized that she was getting angry, she was forgetting, she was getting depressed. She would suddenly be found alone crying. And then the worst thing that happened was I got transferred overnight. You know how it is with government jobs. I was transferred to Delhi and I had to move. And I said, I can't leave this lady alone now. So I just, overnight, we packed her bags and got her shifted to Delhi. And that probably got her even more confused, because she lost track of her familiar surroundings, her homes. She kind of, her furniture, everything was different. And so for the first 2 or 3 years, I was struggling with not trying to understand how to, I really had no way of knowing how to deal with this. I didn't know if I could share this with anybody. I was still feeling a little embarrassed to tell people that I had a mother at home. This, super bright, super smart mother of mine, whom I always boasted about, was having these kind of issues. And then, of course, just the sheer lack of time and effort. And obviously one is, how it is with most mothers and daughters, you're always fighting, and you're always, there's always this love-hate all the time. So there was always, she would retort, I would retort back, and that would make it worse. So almost for 3-4 years, that's how we went. She would run out of the door. We had to find 2-3 attendants to look after her. We had to keep the house under lock and key often. She went out once, and I actually had to have a police search and find her and come back. I had no idea what to do. And then suddenly, I don't know, I guess it was divine providence. I started searching the net and I said, look, let me try to see if there are any organizations. In fact, I actually started out with looking for a home where I could keep her, very reluctantly, because I really didn't want to, she was my only parent for so many years. So I really didn't want to lose her physically for any time, but I thought I just couldn't handle it anymore. My children were doing their board exams. My husband had a tough job. I had a tough job. We had challenges at work. So in the midst of all this, I said, let me look. And I don't know from where out emerged ARDSI. And I just called the helpline and they said, we have this daycare center. So we are willing to share your burden by, ask her to come and spend time with us. And let her, we'll take care of her. We will, there'll be therapy for her. We'll also help you get appointments with some of our best doctors. So why don't you come? And that's how I got associated with the ARDSI. And today, though it is the Alzheimer's Day and this is a function of ARDSI, I'm not saying this because of that. There was a real change in my entire handling of the problem from the moment I entered the portals of ARDSI. Of course, the financial issues, the anxiety of her losing her bank accounts, her pension, those things, because I was in government and I knew how to handle those issues. My sister and I also having this absolute wonderful relation between us, we had managed those things. And those, I'm just trying to say it here for the sake of others, that yes, what Dr. Manjari said, to ensure that you have a will ready, or you at least know where you're going to do, how you're going to handle their finances and their assets, and how they're going to be treated, because Alzheimer's is an expensive disease as well, because all caregivers do need support. So do remember, you have to keep your finances and your monies in place. But the best thing that ARDSI did, in addition to, giving me all this information, was that we could gradually, as far as her medicines were concerned, first, of course, because she was very aggressive, we had to give her some calming antidepressants. And I think Dr. Manjari, I shouldn't mention that the tablets and things, but whatever she gave helped her calm down. And then after a couple of months, we found that she was sleeping a bit too much. And then we went back to Dr. Manjari, and immediately a couple of medicines were tapered off. And then over and over the years, she suffered for almost 10 years, out of which about 4 years we did with ARDSI. So over the 4 years, her need for medicines went down to the point that in the last year, we almost gave her absolutely no medicine at all. I didn't give her even her regular medicine that she had been having for her heart problem. And she calmed down. The best thing was I learned that I'm not alone in this battle. Several people have suffered like me. Several people have had this problem. I didn't suffer, but my mother suffered. And I don't know if she physically suffered, but yes, I at least knew that there are many more people in this situation. I shouldn't feel sorry for myself. I should reach out, and I shouldn't allow my frustrations or my lack of being able to handle this come in the way of my dealing with her in her last years. So thank God for ARDSI, because they helped me calm down. They helped me. They taught me more than they did anything else. They taught me to be a better caregiver. I learned that I have to handle it more patiently. I also learned of several ways of entertaining her or engaging her, keeping her in active, of feeling relevant. And that was very essential. So that happened because I realized music was something she enjoyed. She enjoyed chanting. She enjoyed knitting. So we started bringing in these activities gradually into her life. And the best thing was all of us were getting this 7 to 8 hour break every day. So we didn't have to deal with her for those 7-8 hours. So we could kind of recharge our batteries and be ready to receive her with a warm smile and a welcoming smile when she came back. Because if you have to deal with an Alzheimer's patient 24 hours, 365 days, it is indeed extremely challenging. And I had 2 young children at home. I had my maid and her child at home. I had my husband with me, and I had my sister who was always there to support me. And despite all that, I thought I didn't have enough people. So I can quite imagine how terrible it must be for people who have to deal with this alone. So my only advice to everyone who's probably who has elderly people at home who are displaying such signs, or who feel that they know of friends or neighbors who have suffered or are suffering, just reach out. I think a similar thing happened with Corona. We realized that those people who reached out and asked for help got help and survived. And those who kind of hid under fear or humiliation or feeling shy or whatever, they were the ones who really had to suffer a lot. So let's come out, let's remove all these stigmas. And I think we have to be open about it. And as a small contribution to that, my mother passed away 3 years ago. She would color, she was drawing, she used to love making those little envelopes and bags that ARDSI made her make. And one felt so lovely to see someone we had given her up as a hopeless case. And here was this hopeless case coming back with such wonderful creative activities. She was singing songs. So, we felt very, very nice. And that brought us into believing that we can manage this disease. We can, if we understand it better, and if we can treat it, it can't be treated, but if we can manage it better and reach out to the right kind of medical doctors, especially someone like Dr. Manjari. I cannot stop saying this several times, because I know there have been many, many doctors that we went to. I don't want to belittle any of them, but the biggest advantage I had with Dr. Manjari was she never treated her as a doctor. She treated her she was like a daughter. So we would go for picnics, and Dr. Manjari would talk to all the patients, all of them, as if, she was one of the caregivers. So most of them thought that this was just one of the caregivers. They didn't even realize that this was a doctor. And then you quietly, because a lot of Alzheimer's patients or dementia patients do have this fear of doctors and medicines and those MRI scans and things like that. So there again, this was helpful. I know I'm taking too much time. So before I end, I just want to basically just to share with you, because I know that many people don't like to show these pictures and these photographs, but if I can just share my screen, I want you to realize how it helped after post Alzheimer's, when my mother used to come home, and how singing and knitting helped her. So if I can just show a 1 minute video to just have you see how these kind of activities can keep them entertained or engaged. So I'm just sharing my screen. I hope it works. This is Mummy. I hope you can see my screen. Can you see it?
Yes, we can see.
Yes.
So this is Mom singing. Wait, I'll just bring it.
Yes, we can see. Yes.
Yes. This is when she returned from the ARDSI office. So this was her singing Itna na mujhse tu pyar badha. And then this is her trying to knit. I hope it works. If it does, then I'll. Oops. I think it's not downloaded. Okay. Anyway, this was her knitting. This is her at the Alzheimer's, at the care center with one of the caregivers. Look at the kind of affection with which she was taken care of. She used to enjoy being there. And this is her with a young child. I think Dr. Manjari did mention keep pets or some little kids. So my maid, I in fact hired this maid because she had this little child with her. Then my mother would just hug her and hold her. And she started calling her Sharda because she thought this was me. And she'd start crying if the kid was taken away and all that. But this kind of helped her, come back to. So here she is happily knitting. I can't find the one where she's not knitting properly, but here you have a photograph of her doing the same knitting. So basically all these activities that ARDSI helped us with really got us back to some kind of, sorry, I'm just stopping my share and getting back to, yeah. Sorry. So that was Mommy and her journey with ARDSI. And I think I'm also grateful to them because, and also grateful to God that she didn't have to eventually suffer getting bedridden or those kind of problems. She was lucky in the sense that she lived a very dignified life, and except for a little bit of help with the toilet and bath, she did most of her activities. She could walk, she could eat. Till the last day she ate, and she passed away peacefully at home on her own bed on a full moon night, like tonight. And I'm always going to be grateful for that. But I must say that what Alzheimer's taught me is that we must learn to be patient, and we must learn to love those who really have spent their entire life molding and nurturing us. And so unless and until we are able to go there and understand it. And we must be kind to ourselves. I think a wonderful thing that ARDSI taught me was don't feel guilty, because, yes, she would hit at times, she would get aggressive. And sometimes you also, in your anger or in your hurry, you also go and hit back. And, you suddenly you don't, and then when you realize that you have struck her, you feel so guilty that for the next 3 days, you're just kind of, I'm sorry, somebody's screen sharing here. So you also become a little, worried. So, oops.
Thank you. Thank you, Shadaji.
Thank you so much. I think there's some, thank you very much.
Shadaji has joined the ARDSI, and hopefully the reason ARDSI is able to help the caregivers is because each and every one of our system support volunteers, member secretaries, executive members, all of them are those diamonds who have been polished as caregivers because they have looked after their loved ones with dementia. So this is our resource. These are the people who have actually learned everything the hard way, even when the Delhi chapter was not there, started things on their own and got it moving. So they know firsthand from personal experience how to manage the person with dementia. The pill, the drug is just a minimal part of it. It's not even 10%. I would say maybe sometimes 25% of the management. But 75% of the management is the skill by which these, Veena ji, Renu ji, Reva ji, Nutan, Beena is such a great resource. She's written a wonderful book on her mother's, her journey with her mother, and one must read that. So we welcome you also into this fold of, giving your experience to others and how it could help others, because the greatest way to prevent dementia, one of the greatest way to prevent dementia, is to have a purpose in life. It has been shown that people who at a later age, even young, have a purpose in life. That is, there is something they are doing to make an impact somewhere else, to change something for the better, have a lesser risk of developing dementia. We haven't talked about what prevents dementia, but one of the things is to have a purpose in life. And let me tell you, all of my young girls and boys over here, I call them young because they may be 60, they may be 70, they may be 80, but they're young in the mind. They have a purpose of life in bringing about change in the caregiver's life of a person with dementia. So with this, I'd like to thank you once again, and I hand over to Renuji.
Thank you so much, ma'am. Wonderful.
Okay, now the floor is open to question and answers from the participants. Narendra, can you take this on and see if you've received any questions and who will answer them?
Yeah, sure. So I have a lot of messages. Like I even have a message from Madam Sita Vaidilingam. So she's there, and then she said it is quite, now I'm back into this familiar place. So we don't have much questions here, and we have some, like somebody had asked about Colonel Khanna also. So
yes.
Colonel Khanna, yeah, he is okay, and he couldn't just be present today. He's just fine.
He's doing well, but we must pray, because all of us are aging. So we must pray for good health, particularly in COVID circumstances. All of us should be. Somebody asked, is Alzheimer's curable? What I can say is Alzheimer's is preventable. And if you detect it early, the progression is, it can be kind of, progression can be kind of staved off. It can be pushed by a few years. So that's what we would reply. I think we can close. We are 1 hour into the session.
That's right. Okay, so now it's my pleasure to invite Mrs. Reva Puri, Executive Director, to give a vote of thanks. Reba, please come on the floor.
Thank you, our respected Chairperson, Dr. Manjari Tripathi, our special guest, Dr. Anu Gupta, and Mrs. Sharda Subramanian. Dear friends, thank you very much for joining us, and we are very happy to have you with us. I hope your presence will be with us forever like this in the coming days. We extend a heartfelt gratitude to all those who are here and to those who have given a helping hand to our society, which serves the unfortunate attacked by Alzheimer. I thank you once again for your support, and your presence and your support is utmost important to us. Thank you very much from our society and from all of us.
Good night.
Good night to all, everyone.
Good.
Good night. Thank you.
Thank you.